Good morning, dear colleagues and friends. It's a great pleasure to welcome you all to the Onco-Egypt Pathology Workshop. I would like to welcome our international guest speakers who join us during our conference. We have Professor Aaron Hahn, champion of lab and hospital accreditation, and Deputy International Commissioner of the College of American Pathologists, and Professor Maher Soghayr, Chairman of the Pathology Department, King Hussein Cancer Center from Jordan. Also joining us virtually from Spain, Dr. Laura Comerma, Professor of Breast Pathology at Hospital Del Mar. Special thanks go to all chairpersons, faculty, and attendees. Please enjoy the workshop this year. أنا عندي بس رجاء إنه إحنا بس نعمل الموبايل بتاعنا سايلنت علشان ما نزعجش السبيكرز. وبشكركم وإن شاء الله يعني أتمنى ليكم وركشوب يعني هادي وظريف. شكرا ليكم.
I'm Professor Dr. Manal Fawzi Gadallah, Head of Pathology Department at Shams University. I'd like to introduce today our Professor Dr. Nafisa El-Badawi, and she's a colleague and a professor in our Department of Pathology at Shams University. She's gonna give us a talk about the updated WHO classification of breast carcinoma. We all know that Professor Dr. Nafisa is the head of the Scientific Council of the Egyptian Fellowship of Pathology and a member of the Scientific Council of the Arab Board of Pathology.
Okay. Good morning, dear all. It's my pleasure to be with you today, and I have to thank the organizing committee, particularly my dear colleague, Professor Dr. Manal El-Mahdi, for inviting me to be with you today. I'm going to talk about updated WHO classification of breast carcinoma. The objective of this talk is to highlight and understand the changes in the latest WHO classification of breast carcinoma. The WHO classification, the latest one for the breast, was released in 2019, and as much as it looks very busy and complicated, it's much easier and more applicable and practical than the previous edition, which was the 4th edition. What are the major changes in the 5th edition? First, we talk about invasive breast carcinoma. In the 4th edition, there were many types and many subtypes and many special types. In the 5th classification, they gathered these types in groups under the umbrella of invasive breast carcinoma. To know a word about invasive breast carcinoma, no special type, the nomenclature was changed over the years. In the 1st edition, it was called infiltrating carcinoma. And in the 2nd and the 3rd, they were called invasive ductal carcinoma. Then, in the 4th edition, they changed the name into invasive carcinoma, no special type. In the 5th edition, they changed the name again into invasive breast carcinoma, and it included many patterns. The first thing that we notice as a change from the 4th edition to the 5th edition is that the term infiltrating duct carcinoma was omitted in the 4th edition. But they put it back again into in the 5th edition under the umbrella of invasive breast carcinoma. Secondly, there were many rare entities that they were put under special types in the 4th edition, like oncocytic carcinoma, lipid-rich carcinoma, glycogen-rich clear cell type. All these were included as special types in the 4th edition. In the 5th edition, they were all gathered under the umbrella of invasive breast carcinoma, which in essence means invasive breast carcinoma, no special type, however, it has a certain pattern, maybe a pattern of infiltrating duct carcinoma, of oncocytic, of lipid-rich, whatever the pattern. And why they did that? Why they gathered them all under the umbrella of invasive breast carcinoma? First, because these rare types are rare, really, and because the prognosis will not change for the patient if they have this pattern or that. The prognosis will depend on grade, lymph node status, stage, and molecular subtypes. Also, the prediction for treatment will depend only on ER, whether positive or negative, HER2, whether positive or negative. The PR was omitted as a factor for prediction of hormonal treatment in the 5th edition. However, the PR has a role because when ER and PR are positive, the patient will respond better to hormonal treatment. If ER is positive and PR is negative, the patient will respond in a lesser way. The second and big change which was done in the 5th edition is that they removed or eliminated medullary carcinoma from the pattern and from the types. In the 4th edition, the medullary carcinoma was put under medullary carcinoma, atypical medullary carcinoma, and invasive carcinoma, no special type with medullary features. All these were omitted or eliminated in the 5th edition. And why did they do that? Medullary carcinoma, as we know all, has the criteria of being well circumscribed or having a pushing border. It is formed of syncytial architecture, cellular architecture, and a high-grade nuclei. Maybe we can find necrosis and prominent tumor infiltrating lymphocytes. The medullary carcinoma had many things that many issues that they didn't like, because there was poor inter-observer reproducibility, there was overlap of histological features with carcinomas of basal like molecular profile and carcinoma with BRCA1 mutations. There was no consensus on the prognosis of such tumors. Sometimes they say they are of good prognosis, sometimes they say they are of bad prognosis. Now this dilemma has been explained by understanding the role of tumoral infiltrating lymphocytes and their role in prognosis. Many studies have been done to understand the behavior of medullary carcinoma, and they reached a conclusion that the percentage of lymphocytes in the tumor have the big role in the prognosis. And so they started to define the area of the tumor, and then they define the areas of lymphocytic infiltrate, excluding the areas of fibrosis and necrosis, and counting only the areas where they have lymphocyte and plasma cells, not the neutrophils or the histiocytes. And then they define the percentage of lymphocytes in the tumor. If the percentage of the tumor infiltrating lymphocyte in the tumor is less than 10%, this is a sign for bad prognosis. If it is more than 50%, it's a sign for good prognosis. And so they started, They eliminated the term medullary carcinoma, medullary carcinoma, and introduced the name tumor infiltrating lymphocyte rich invasive breast carcinoma, no special type. And because of the variability of the amount of lymphocytes in the tumor, they said we have tumor infiltrating lymphocyte rich breast carcinoma, which have a good number or a good percentage of lymphocytes, and another type, which is the other end of the spectrum, which would be called invasive breast carcinoma with medullary pattern. The second change is in the neuroendocrine neoplasms. In the 4th edition, we had neuroendocrine tumors under 3 types. Neuroendocrine tumor, well differentiated, neuroendocrine carcinoma, poorly differentiated, and carcinoma with neuroendocrine differentiation. In the 5th edition, they decided we will have only 2 types. Neuroendocrine tumor, not otherwise specified, and this would be grade 1 or 2, and neuroendocrine carcinoma, not otherwise specified, would be a small cell type or a large cell type. This change was triggered by the fact that neuroendocrine tumors of the breast are rare. Neuroendocrine differentiation can happen in many cases. In about 10 to 30% of the breast carcinoma, they have some sort of neuroendocrine differentiation. And it is common with some types like solid papillary carcinoma or mucinous carcinoma. And the recommendation now is that we don't do routinely neuroendocrine markers. We do them only if we have the pattern that is compatible with neuroendocrine tumor, morphological pattern of neuroendocrine tumors. Then we use synaptophysin or chromogranin to confirm this identity. In the 5th edition, they added 2 new entities that were not present in the 4th edition. The first one is the mucinous cystadenocarcinoma, and this one was put under the umbrella of invasive breast carcinoma. It is characterized by cystic spaces. It is characterized by cystic spaces lined by tall columnar cells, and they have intracellular mucin. And they resemble ovarian and pancreaticobiliary carcinomas. So we have to identify that there is a primary tumor that arises from the breast that is mucinous cystadenocarcinoma, so that if we see this one, we don't jump into diagnosing a metastasis. We have to prove first if it is primary or secondary. The second thing is that we have to differentiate it from encapsulated papillary carcinoma, which has a better prognosis. How to differentiate both of them? Mucinous cystadenocarcinoma of the breast is ER negative, PR negative. Encapsulated papillary carcinoma is ER positive and PR positive. Of course, they are positive for intracytoplasmic mucin, and the papillary carcinoma would be negative for mucin. Mucinous cystadenocarcinoma is cytokeratin 7 positive, cytokeratin 20 and CDX2 negative. The second entity that they added is the tall cell carcinoma with reverse polarity. In the 4th edition, we had 2 entities. One is called solid papillary breast carcinoma, resembling tall cell variant of papillary thyroid neoplasm. That was a very complicated name. The other entity was the solid papillary neoplasm with reverse polarity. Examining both entities, they found that both share in the same mutation for IDH2 and PIK3CA mutation, so they grouped them together and they put them under the name of tall cell carcinoma with reverse polarity under the entity of rare and salivary gland tumor types, and this was to avoid the confusion about the name, or if we say resembling papillary carcinoma of the thyroid, or we say it is a solid papillary tumor with reversed polarity. It's not a papillary carcinoma anymore. How to diagnose this entity, the tall cell carcinoma with reversed polarity? They have solidness of tumor cells with delicate fibrovascular cores, and the cells have abundant eosinophilic cytoplasm with the nuclei present. With the nuclei present at the upper pole of the cell, not as we know that the nucleus is always in the basal part of the cell. That's why they call it reversed polarity. The nuclei may have grooves and inclusions, and the myoepithelial cells are absent because they are invasive tumors. Cytokeratin 5/6 is positive, and they are triple negative for ER, PR, and HER2. They have, in most cases, IDH2 mutations, and they are high-grade tumors in spite of the fact that they look bland morphologically. The differential diagnosis would be solid papillary carcinoma, which has a much better prognosis. Another change is the mixed carcinoma. In both the 4th and 5th editions, to diagnose a special type of tumor, we have to have 90% at least of the tumor is composed of this type. In the 4th edition, they said if you are going to diagnose a mixed carcinoma, you have to have at least 50% of the special type to diagnose mixed carcinoma. In the 5th edition, they said no. If we have 10% up to 90% of the other type, we will call it mixed carcinoma. And we have to define the percentage, and we have to grade both tumors separately because they might behave in a different fashion. So we have to grade them separately, and we have to define the percentage of each tumor because if it is a higher grade tumor, then we know that it's only 10% that will behave in a bad way. If it is more, we'll know that it will behave according to the one that is worse in prognosis. One other change was about mitosis. In the 4th edition, they were counting mitosis always per 10 high power fields. In the 5th edition, they decided no, we'll count mitosis per square millimeter. And this is more accurate and more appreciated and universally considered rather than per high power field. Now we come to the inflammatory carcinoma, and the inflammatory carcinoma is a clinical diagnosis. But they asked the pathologist to diagnose the case as inflammatory carcinoma. In the 5th edition, they said, no, we don't have to decide if this is an inflammatory carcinoma or not. We can say that this is a carcinoma. We can describe that there is inflammation, but the name inflammatory carcinoma, we don't say that. It's a clinical entity, and they have to decide that it is an inflammatory carcinoma clinically, not pathologically. There was another debate about bilateral carcinoma. They said if we have bilateral carcinoma of the breast, whether it is synchronous or non-synchronous, meaning it is occurring at the same time or one is occurring after the other. The pathologist has not to worry about this. We have to say this is bilateral carcinoma only. Also, if it is both of them are primary or one is metastatic from the other one, we don't have to worry about this. The pathologist has to say that this is a bilateral carcinoma, and then for the clinician to decide the other elements according back to the history, according to the radiology, according to other clinical signs that he can know if it is synchronous or non-synchronous, metastatic or primary. One word about fibroepithelial tumor. Phyllodes tumor has changed in the 5th edition. In the 4th edition, they said, if we have areas that are composed of well-differentiated liposarcoma, this is enough to say that this is a malignant phyllodes tumor. Then came the 5th edition, and they said, no, areas of well-differentiated liposarcoma are not to diagnose malignant phyllodes, and we have to search for other criteria of malignancy, like invasive margin, like cytological atypia and necrosis and mitosis. These are criteria for malignancy, but the well-differentiated areas of well-differentiated liposarcoma areas are not criteria for malignancy. And why they came to this conclusion? Because they found that these areas lack the MDM2 and CDK4 amplification, which are seen in well-differentiated liposarcoma elsewhere, and which are responsible for the malignant behavior and the metastatic ability of the tumor. This is about invasive carcinoma. If we turn to the pre-invasive tumors, we have a change in lobular carcinoma in situ. And they say that in the 4th edition, we had classical lobular carcinoma in situ and pleomorphic lobular carcinoma in situ. In the 5th edition, they added another entity, which is the florid lobular carcinoma in situ. And how to diagnose this one? It's diagnosed by seeing marked distension of the terminal duct lobular units, and it is formed of solid nests of cells, and it resembles the solid type of duct carcinoma in situ, and many times they were misdiagnosed as solid ductal carcinoma in situ. They are, however, cadherin negative, so they are not of ductal origin, they are of lobular origin. And the importance of this one is that in 25 to 60% of cases, they were associated with invasive carcinoma, or they can progress into invasive carcinoma. So if we see this pattern, we have to search carefully for invasive carcinoma and search for it and diagnose it. And if we see it at the margin of the tumor, we have to report it. It's an important thing to report it if it is at the margin of the tumor. One word about microinvasive carcinoma, which poses many debates also. Microinvasion is invasion beyond the basement membrane and myoepithelial cells less or equal to 1 millimeter. And this is invasion of the stroma, the interlobular or periductal stroma. Like here in a case of ductal carcinoma in situ, there is invasion beyond the basement membrane, and it should be surrounded by reactive stroma in the form of edema, in the form of dysplasia or inflammatory infiltrate. This is another example of lobular carcinoma in situ with area of microinvasion here. And if we see microinvasion, it should be reported, and we should look clearly out closely for the presence of a true invasion to diagnose it as invasive carcinoma. And if we decide that this is only microinvasion, then we have to report it, and here the stage of the tumor will be changed from PTIS for in situ carcinoma into PT1 MI for microinvasion. And This is important because it affects the prognosis, and also in many reports they say that in about 4% of the cases of microinvasive carcinoma, they found positive sentinel lymph nodes. So they affect the prognosis of the patient. These are the changes, or the major changes that were found in the fifth edition, and I think they made the fifth edition more easier, more applicable, and more practical than the fourth edition. Thank you.
Thank you so much, Professor Dr. Nafisa Al-Badawi, for this comprehensive and simplified talk. Thank you.
Well, you cannot imagine how much I'm proud to present my dear old friend, Professor Ahmed Abdelaziz, Professor of Pathology, Faculty of Medicine, Cairo University. Professor Abdelaziz is very well known, and he is actively engaged in all areas of pathology and all efforts to improve the service and the education in Egypt. Professor Abdelaziz will talk us on a very important and practical point: the diagnostic challenges of core needle biopsies, interpretation of the breast.
Okay, thanks. Good morning, everybody. Thank you, dear Professor Gamal, Dr. Manel. Thank you for your introduction. Thank you, Dr. Manel Mahdi, for inviting me for the third time to this great conference. Today, I shall speak about an important item, which is diagnostic channels that we face of core needle breast biopsy. As you know, nowadays, all breast samples we receive must be as a core biopsy, not fine needle aspirate cytology. Only fine needle aspirate cytology is used for cystic lesion, but any solid lesion in the breast must be biopsied through guided core needle biopsy. In core needle biopsy, as you know, we have malignant and benign, black and white, and the gray zone. This gray zone, I shall speak about it. What about the difficulties we shall face in this core biopsy? We have about 4 items of difficulties in core biopsy. First of them is intraductal lobular epithelial proliferations. In core, today I shall speak about only core biopsy, okay, not excisional biopsy. First problem is intraductal or lobular epithelial proliferations. Intraductal lobular epithelial proliferations include usual ductal hyperplasia, atypical ductal hyperplasia, ductal carcinoma in situ, low grade, lobular neoplasia, as Professor Nafisa said to us just now. Usual ductal hyperplasia, it is a component, it is a component of fibrocystic changes showing mixed proliferation of cells of luminal and myoepithelial cells, which is very important for proliferation post-component, epithelial and myoepithelial, associated with slight increase in breast cancer risk. Cytologic features. These are examples of usual ductal hyperplasia. Cytologic features, mild variation in cellular and nuclear size and shape. Maybe looks like normal cells, or maybe very mild variation from the normal. Relatively small ovoid nuclei with frequent elongated or asymmetrically trapped pear-shaped forms. This ما تخلوهم يوطوا شوي. These ovoid nuclei ده ولا مش مشحون؟ اللي بيعمل الحركه بتاعته بطيئه قوي. مفيش خالص. بدأ؟ انا مش شايفه على الشاشه. المهم. Okay. In the first figure, we can see some oval or carrot-shaped nuclei. These are myoepithelial cell admixed with ductal epithelial cell. This is the normal or usual ductal epithelial hyperplasia. Regarding architecture features, ده شغال فين بقى ولا اي حاجه؟ هو بطيء قوي. Okay. Regarding architecture features, cohesive proliferation with haphazard arrangement or streaming growth pattern. As you see in the second figure, there is proliferation, architecture, proliferation, or growth pattern, or just streaming of the cells, like streams. الدورينترز ما فيش فايدة فيه. وبعدين هم بيروح خلاص. We can find irregular slit-like fenestrations are common, especially along the periphery, which is very important. If you are fixing and you use a neutral buffered formalin and you fix tissue immediately, and following the rules of CAP to be fixed from 6 maximum to 48 or 72 hours. So there will not be retraction between the epithelial cells or myoepithelial cells and their surrounding stroma. If the tissue is not fixed well, there may be artifact retraction. If it is fixed well, normally there will not be retraction. So in this case, if we have a specimen which is fixed well, and we found the slits between the nests of epithelial cells and the stroma, these clefts indicate that it is not an intraductal carcinoma. Cells run parallel to the edges of secondary spaces and don't exhibit polarized orientation in contrast to with cells of atypical ductal hyperplasia. As you find here in these cystic spaces, the cells are parallel to the edge of the cystic. So it is not perpendicular. If they are perpendicular, it is an atypical or even in situ carcinoma. Immunohistochemistry may play a role in these cases. High molecular weight cytokeratin, like cytokeratin 5/6, we can see mosaic pattern to the right of the screen. Estrogen receptor, heterogeneous positivity with variation in staining intensity, as you can see here. Because some cells, like normal بالظبط, if you stain normal mammary lobules or ducts, you may have some cells with strong staining, moderate staining, or weak staining. Also, in usual ductal hyperplasia, we can find this, and this also, some cells may be negative. These cells actually are myoepithelial cells. So inside the duct is a mixture of epithelial and myoepithelial cell proliferation. Second item of hyperplasia is atypical ductal hyperplasia. Actually, it is very difficult item. Intraductal colonal epithelial cell proliferation with cytological and morphological features similar to low-grade ductal carcinoma in situ. So the difficulty is between atypical ductal hyperplasia and low-grade carcinoma in situ. Differentiation from low-grade ductal carcinoma in situ by size equal or less than 2 millimeter or space occupied by clonal cell equal or less than 2 space. Actually, sometimes it is very difficult in core biopsy to measure the area of a typical ductal or carcinoma in situ to differentiate between them. Because sometimes the core is small, fragmented, not complete. So it is actually it may be very difficult, and sometimes we cannot reach final diagnosis. So in this case, excisional biopsy with safety margin will solve this problem. Cytologic features of atypical ductal hyperplasia, if there is atypia, and we shall found well-defined monomorphic cells with evenly spaced small rounded nuclei, like those in the right figure. Architectural features, variable patterns. We may find solid, cribriform, like carcinoma in situ. Micropapillary, uniform thickness of rigid bridges of arcades. All these may be found in atypical ductal hyperplasia. Immuno may help us in some cases. They can be mixed with usual ductal hyperplasia within the same lobule. If nuclear atypia warrants the diagnosis of intermediate or high-grade ductal carcinoma in situ, atypical ductal hyperplasia should not be diagnosed. If we found that the cells and their nuclei are of intermediate or high grade, so it is not a typical hyperplasia. It is a carcinoma in situ. So the difference is between, or the difficulty is between atypical ductal hyperplasia and low-grade carcinoma in situ. Immunohistochemistry, strong and uniform ER expression, negative cytokeratin 5/6. Ductal carcinoma in situ, low grade. Actually, intermediate and high-grade carcinoma in situ, it is more easy to diagnose in core biopsy rather than this type of carcinoma. The same histological and immunohistochemical feature of atypical ductal hyperplasia, but it is 2 millimeter or more, or occupying 2 spaces, more than 2 spaces. Actually, it may be difficult in core biopsy. Here is a table to differentiate between usual, atypical, and low-grade ductal carcinoma in situ. Another thing, in the core biopsy, we may face difficulty, lobular neoplasia, either atypical lobular hyperplasia or low-grade lobular carcinoma in situ. Both hyperplasia and the classic lobular carcinoma in situ are considered risk factors for development of carcinoma, as Professor Dr. Nafisa said to us. Lobular neoplasia is often bilateral, multifocal, and associated with increased risk of invasive carcinoma. Lobular neoplasia, Herber E. cadherin mutation, can be demonstrated negative by E. cadherin immunostain, like this picture. If we have in core biopsy like this, we cannot differentiate between if it is in situ duct carcinoma or in situ lobular carcinoma. So we can use E. cadherin stain like in this figure. So there is no inside the lobule of positive staining, and only at the periphery we can find lobular staining. So it is lobular neoplasia and not duct carcinoma in situ. Classic lobular carcinoma in situ consists of an intralobular proliferation of small uniform cells, which at least 50% of acini in the lobular unit are distorted and expanded. And our big professors taught us that you can diagnose lobular carcinoma if we are finding ballooning of the terminal duct lobular system. This ballooning or expansion of the lobules indicates that it is lobular carcinoma in situ, and nowadays lobular carcinoma neoplasia or in situ neoplasia, which actually not considered as tumor. Atypical lobular hyperplasia, this is the same. Lobular neoplasia, differential diagnosis, ductal carcinoma in situ, and the cancerization of the lobule. Or myoepithelial hyperplasia. Sometimes it is difficult for us to differentiate both lobular carcinoma in situ or hyperplasia and or between ductal carcinoma in situ and the cancerization of the lobule, like vagetoid spread of duct carcinoma inside the lobule. So if we have this, we can differentiate, and it is not easy by H&E, we can differentiate it by E-cadherin. Okay, we found that E-cadherin stain the ductal cells, and the lobular cells will be in the center and surrounded by ductal cells. This is the vagetoid spread or cancerization of the lobule by ductal carcinoma in situ. The other thing is myoepithelial hyperplasia, what we call sometimes the epithelial myoepithelial hyperplasia, and even sometimes we have tumors of epithelial myoepithelial low-grade adenocarcinoma, which looking like those of salivary gland. Myoepithelial hyperplasia can be differentiated by myoepithelial marker, and my advice for you, if you are using a marker for detection of myoepithelial cells, you must at least use two markers. At least two markers, one nuclear and one for cytoplasm. The difficult thing in core biopsy actually is fibroepithelial lesions. Fibroepithelial lesion, the distinction of low-grade phyllodes tumor from cellular fibroadenoma in core needle biopsy can be problematic due to overlapping histologic features. As you know, fibroepithelial lesion or fibroepithelial proliferation include fibroadenoma and phyllodes tumor. To differentiate actually between them, you must have an excisional biopsy. But in needle biopsy, if you can't, you just diagnose it as a fibroepithelial lesion for total excision with safety margin. Okay? Actually, it's you facing fibroepithelial lesion with less cellular stroma, this may be phyllodes tumor, and this may be borderline or malignant. As you know, phyllodes tumor stroma is heterogeneous. Maybe in some area it is hypocellular or moderate cellular or highly cellular. So actually, if you don't have a good radiologic picture of the case, and even if you have, it is better if you found it is a fibroepithelial lesion as a routine excision with safety margin. Differential feature between low-grade phyllodes and cellular fibroadenoma: stromal cellularity, infiltrating or pushing borders. Sometimes you may have a part of the border between the tumor and the surrounding breast, but sometimes in core biopsy you may find not. So this infiltrative or pushing border is good in excisional biopsy, not in core biopsy. Presence of leaf-like pattern, sometimes we may find, we may not find in core biopsy. Stromal overgrowth, atypia, mitotic figures, pleomorphism, necrosis. If you found the stroma, there is atypical cells, stromal atypical cells, increased mitotic activity, especially abnormal mitosis, necrosis, it is actually a malignant phyllodes tumor. Okay? But for most of cases, we diagnose it as fibroepithelial lesion for total excision with safety margin. Here is the difference between the fibroadenoma and the low-grade phyllodes tumor. Problems in distinguishing benign phyllodes tumor from fibroadenomas in core biopsy. As I told you, first thing, fragmentation of cores with cystic spaces between cores mimicking leaf-like architecture. So give an impression of phyllodes tumor, but actually it is a fibroadenoma. Stromal hypercellularity is heterogeneous and variable and may be missed by sampling. You may take an area with hypocellular area and not hypercellular. Lack of atypia and mitotic activity in low-grade phyllodes tumor. Lack of distinguishing radiographic features. Sometimes with modern machines in radiology, they can diagnose phyllodes tumor. Actually, those colleagues of radiology now have very advancing machine to diagnose and know carcinoma in situ, invasive carcinoma, phyllodes tumor, and I think after very few years, our role will be minimized, okay? This picture is very important picture. If we found an adipose tissue inside the stroma of this core biopsy of fibroepithelial lesion, it indicates it is a phyllodes tumor, mostly not fibroadenoma. However, there are reported cases of fat infiltration or fat lobules in the stroma of fibroadenoma. But mostly it is with the diagnosis of phyllodes tumor. There are no reliable immunohistochemical stains to distinguish phyllodes tumor from fibroadenoma. Actually, Ki67 is very important marker, but we can apply it for core biopsy, but it is the core biopsy is representing very minimal sample of the tumor. But we can apply Ki67 on excisional biopsy on hypercellular area, actually for detection of proliferation activity of this tumor. Sometimes it is difficult to count mitotic figure. As you know, phyllodes tumor look benign or intermediate or borderline or malignant according to the number of mitoses per 10 high power field. Okay, so sometimes it is difficult to count the mitotic figure. So we can use Ki proliferation index in this case. The third difficulty is in papillary lesions of the breast. Papillary lesion of the breast, first of them is papilloma. Papilloma, just a simple papilloma, characterized by finger-like fibrovascular stromal cores lined by epithelial cells. The histologic discrimination is based mainly on presence or absence of very important component, which is myoepithelial component. Papillary region of the breast, we have a benign and we have malignant. Benign intraduct papilloma or papillomatosis. Intraduct papilloma with atypical proliferation, atypical papilloma. Actually, I hate this term, atypical papilloma. Malignant, we have papillary ductal carcinoma in situ, encapsulated papillary carcinoma with invasion, solid papillary carcinoma, or invasive papillary carcinoma. These are the types of papillary region of the breast. Intraductal papilloma and papillomatosis. What is the difference between papilloma and papillomatosis? Papilloma is large central lactiferous duct. In lactiferous ducts, near the nipple. Okay? It is mostly solitary, present with nipple discharge, bloody discharge, grossly dilated duct with papillary fronds attached by one or more pedicle to its wall. Okay. Papillomatosis occurs commonly in terminal, away from the nipple. In terminal duct lobular units, usually multiple, often clinically occult and discovered incidentally by mammographic calcification, and grossly it is an occult. And we can find it commonly in areas of fibrocystic disease or fibroadenosis. Here is the intraductal papilloma, dilated duct showing papillary growth with arborescent, usually broad fibrovascular cores. This wide or broad fibrovascular cores is very important, actually one of most important feature to differentiate between papilloma and papillary carcinoma. Because papillary carcinoma, the cores are very thin, but in papilloma, it is very thick and fibrotic. Lined by outer epithelial layer with retained myoepithelial cells lining. As you can see, if you can stain with myoepithelial marker, we can find complete lining of the papillae by myoepithelial cells inside the proliferation inside the duct and outside in the wall of the duct. So this is the intraductal papilloma. The epithelial component may show foci of usual ductal hyperplasia. Sometimes you may find the area inside papilloma like ductal hyperplasia, which is increased proliferation of epithelial cell. Apocrine exchange, which is very common, and squamous metaplasia may be seen most often association with areas of infarction, typically seen after needle biopsy. And after needle biopsy, we can find if there is an excisional biopsy, complete infarction of the papilloma. True necrosis may be present and should not be confused for ductal carcinoma in situ. Intraductal papilloma take care of sclerosis and the biopsy site. After core biopsy or incisional biopsy, in excisional biopsy, we may find some sclerosis as a result of previous intervention in this area. And we may find some entrapped epithelial cells or glands inside this area, like those, if you remember, a thyroid nodule. After core biopsy, we may find in the capsule area of fibrosis with entrapped epithelial cells and may looking like invasion of the capsule. Okay? If it is difficult, we can use myoepithelial marker to found myoepithelial cells inside these areas of fibrosis at the outside of the papilloma. Papilloma with atypia, it is a rare, and actually I hate this item. If it is less than 3 millimeter or more than 3 millimeter, it is not important. Papilloma with atypia. Papillary ductal carcinoma in situ, which is very important, usually multiple dilated ductal lobular luminal spaces. May be associated with other types of ductal carcinoma in situ. Most cases of ductal carcinoma in situ, we can find comedo, solid, papillary, cribriform, mucinous. Rarely we can find a single type alone. How can we differentiate that it is ductal carcinoma papillary type? Cylinder, very thin, branching fibrovascular stalks, typically thin and more delicate when compared to those of papilloma. Epithelial cells show low or intermediate grade of cytologic features, although rare high-grade lesions do exist, but commonly it is of low grade. Myoepithelial cell usually absent within papillae. As you can see here, if you stain with myoepithelial markers, there is no myoepithelial cells. You can find myoepithelial cells at the lining of the duct. As with other types of ductal carcinoma, in situ myoepithelial cell layer is retained at the periphery of the involved duct. This tumor, encapsulated papillary carcinoma, we can see it commonly in older postmenopausal women. It is well defined mass and considered actually as in situ carcinoma. The most important things about this tumor, this encapsulated papillary carcinoma, first, to diagnose it as encapsulated papillary. Second, to search for invasion surrounding this tumor. Third, not to use HER2 or KI in this lesion if there is no invasion, because it is considered as an in situ carcinoma. And actually, it is a struggle between us and some clinicians. They ask us to do or to perform HER2 and KI on this tumor if it is encapsulated only. And actually we refuse, okay? Third thing is the staging. It is considered as carcinoma in situ. And if we found any invasion, so T1 according to the size of invasive area, okay? Encapsulated papillary carcinoma, WHO classify it as in situ lesion. Encapsulated may have associated with frankly invasive component, which is usually ductal NST, and when present should be staged according to the dimension on invasive component. Solid papillary carcinoma. How can we differentiate actually between solid papillary carcinoma and solid carcinoma in situ? It is very important. Grossly solid fleshy nodular circumscribed mass, microscopically single large expansile mass like those or even of lobular carcinoma in situ, or multiple solid closely opposed nodules showing inconspicuous delicate, this is very important, delicate fibrovascular pools leading to solid growth pattern. This high power picture indicate inside these solid areas there is a very thin fibrovascular course, which differentiate this lesion from solid carcinoma in situ ductal or even lobular carcinoma. Okay. The proliferating tumor cells exhibit low or intermediate grade over or spindled nuclei. Solid papillary carcinoma, we may find in some cases that there is peripheral palisading of tumor cells around fibrovascular cores forming perivascular pseudorosettes. We may find mucin and neuroendocrine differentiation are frequent. They frequently lack peripheral myoepithelial cells because we called it is an invasive. So we don't find the peripheral area of myoepithelial cells. This is an example of a solid papillary carcinoma. I have only 2 minutes. Invasive, this is an example of invasive papillary carcinoma, which with prominent desmoplastic inflammatory stroma. And this is the table difference between different types of papillary lesion. True cut biopsy, I cannot tell the whole story in the true cut. You must know this. Through papillary lesions of the breast, you cannot sometimes differentiate if it is benign or malignant. or even in situ. So you write it like fibroepithelial. It is a papillary lesion for total excision with safety margin. Okay. Now, excisional biopsy. By excisional biopsy, I can tell you the whole story. Other thing is mucinous lesions, the last one. The presence of mucin can be seen in a variety of breast lesions as fibrocystic change, a normal hyperplastic, or mucocele-like lesions, or colloid or mucinous carcinoma. This is an example of presence of mucinous lesion, mucocele-like lesion, radial scar. Mucinous carcinoma sometimes may be very difficult in core biopsy because sometimes it is markedly hypocellular, and we can find only floating clusters of benign looking, sometimes normal cells, and you cannot tell. So also the diagnosis will be it is a mucinous lesion for total excision with safety margin. Radial scar and nodular sclerosis are also very difficult to be diagnosed, even in excisional, sometimes in excisional biopsy, and this problem may be solved by myoepithelial markers. Thank you.
Thank you very much, Professor Dr. Ahmed Abdelaziz. He stuck to time and he was giving us a presentable and comprehensive lecture. And now, our eminent professor, Dr. Nadia Mukhtar. An update on molecular classification of breast cancer. And as usual, I'm expecting to find more and more with Professor Dr. Nadia. She always brings new features of diseases.
Sabah al-khair. Good morning to you all. It's a pleasure for me to be here with you, with eminent speakers, chairpersons, and lovely audience. So thank you very much, Dr. Manel, for the kind invitation, and I really enjoy and wish you a very successful conference. I'm going to talk about the updates on the molecular classification of breast cancer. Actually, it is a little bit of a basic classification, but again, we will be mentioning some updates as we go along. So what is the role of this molecular classification? Because as we know, breast cancer is a very heterogeneous tumor or tumors. We've seen a lot of pictures with Dr. Manel and Dr. Ahmed, and it's really a wonderful world. It's so heterogeneous. And it even is difficult to say that it is so many types. No, it is more than that. The fact that it has different morphologic features, different in biology, clinical course, prognosis, and even response to therapy. So the role of this classification, two things actually. It could predict the tumor behavior and hence the patient's prognosis, and also to predict the tumor response to a specific therapeutic regimen. For these two important roles, we have used these are four markers that we're very acquainted with, ER, PR, HER2, and Ki-67. And in fact, these four markers did subdivide the breast cancer into four main types, not just four types, but four main types that are so much different from one another. We have the luminal A, the luminal B, the HER2 positive, and the triple negative group. And they show a lot of variability among them. So there's just 1 minute that we should stop and ask ourselves, why is there so different from one another. The tumors are very versatile and very, very heterogeneous, and they do differ in clinical presentation and in prognosis and response to therapy. And actually, this diagram will tell us all that it is all will go back to the mother cell. This diagram shows us that we have, as the breast, we all have the breast tissue, and the normal development of breast cells come from the stem cell. The stem cell, which then develops into a bipotent progenitor cell. Then it goes on to mature to form the late luminal progenitor, and lastly the differentiated luminal cells. And on the other side, the differentiated myoepithelial cell. So you see there is a cascade of cells that are maturing. Each cell has a function. Now, the stem cell is a cell that is self-renewal with multilineage. It has the capacity to renew itself and also to produce many types of cells. By the progenitor, it has a limited capacity of self-renewal, while if you go down the cascade to the differentiated luminal, it has no self-renewal, but it does the function of the breast, which is secretion of milk and hormone responsiveness. So you see, some cells are there to produce, others are there to do the function. So there is vast difference among them. And that is why when cancer sets in, they follow the mother cell. For example, if mutation occurs at the level of the stem cell, it will produce a cancer stem cell, which will then produce the tumor type called Claudine low, which is known to be aggressive due to its appearance or likeness to the mother cell. And the signature is purely mesenchymal, and we all know that mesenchymal signature is quite aggressive. If we go down and the mutation occurs at the level of the bipotent progenitor, then it will hit the BRCA gene, and hence it would produce the basal-like tumors with a very strong and specific basal-like signature. Go down again to the late luminal, we'll find that it will hit the HER2 gene, and by then it will produce a HER2-enriched tumor, which might or might not show luminal signature, but will not show mesenchymal and will not possibly show basal-like. Lastly, the tumor then hits the differentiated luminal cell or the myoepithelia, producing the very famous luminal A and B types, which have precisely luminal signature and no mesenchymal signature and no basal-like. But if you notice here that the diseases are quite separated by straight lines, however, the signature or the expression is a bit overlapping, a bit vague in between each other, because this is how disease works. There's no sharp demarcation between the expression of the different markers. So you see, if we project that against age, we'll find that the earlier the hit, the younger the age, and vice versa. So that the younger patients below the age of 40 will get the more aggressive forms of the disease, unfortunately. If we look at the overall frequency of our 4 subtypes that we just mentioned, we'll see that the luminal A is the most frequent, to be followed by the luminal B, and then the HER2 positive and the triple negative type. The luminal group, which arises from the mammary epithelial cell, which is surrounding the lumen, and that's how the name is. Luminal A, further subtypes, luminal B, 2 types. So the mother cell here, we're talking about mother cell. Now we know what is the importance of the mother cell because it reflects the biology. The mother cell here is a differentiated luminal or late progenitor in this area. The precursor, the non-obligate precursor, which is not a must, is the atypical ductal hyperplasia, or the ER, the DCIS, which is ER positive. In our material at the Cancer Institute Pathology Department, the luminal group constitutes a majority of 65%. Now, luminal A is the most common subtype. It's usually of low grade, and the pathology or the morphology is ductal carcinoma, invasive ductal carcinoma, NST. Actually, the ductal carcinoma, as Dr. Nafisa mentioned, it is a very heterogeneous tumor in terms of molecular subtype. It can be any type, luminal A, B, negative, HER2, whatever. It's not like lobular. Lobular is more homogeneous. Now, moving back to the luminal group, it is of slow growth, less lymph node metastasis, and overall better prognosis. It has the highest ER PR expression, and also the ER-related genes, the most famously, as we know, the GATA3 and the FOXA1. It is always HER2 negative with low Ki67 below the 20% cutoff value. The cytokeratin profile, as we know, is low molecular weight cytokeratin profile, and it may develop anti-estrogen resistance, and we shall know how. And this is the usual scoring system that we all follow, either the 8 scoring system. We add the percentage positivity to the intensity, and we get a total score of 8/8. Now, actually, some people do not use the intensity as a whole and just declare the thing as percent positivity of a nuclear marker. So that if you would like to say this ER is 100% positive, so it is 8/8. As we said, some people stick only to the percent positivity of the reaction, neglecting maybe the importance or the application of intensity in general. Again, the ER as well as the PR demonstrate a good response. The PR here is 8/8 or 100% positivity. The Ki67 is low, below 20%, and the cytokeratin profile is 8/18. Now we move to the luminal B, which is more aggressive, and maybe it has worse prognosis. The ductal carcinoma here is of higher grades, that is 2 or 3, low to moderate expression of ER-PR. However, there are 3 adverse prognostic factors in this particular group, the luminal B. Either the loss of PR or the positivity for HER2, and lastly, of course, the Ki67 being more than 20%. These are the 3 adverse prognostic factors that decide on the general prognosis of the luminal B group as a whole. It can be either PR low or negative, and hence the HER2 is negative, or it can be moderate or weak ER and PR, and will show HER2 positivity. That's what we call the triple positive. And both of them, of course, will show higher Ki percentages. An example showing the strong positivity for ER, weaker in PR, but positive for HER2, that's a triple positive. The Ki here is high, much higher than 20%. Now, GATA3 and mammaglobin are 2 important markers that we use if we have metastasis of unknown primary. You've all been there, and we use them to help us locate the primary tumor of the breast. It mostly specifies the luminal subtype or identity of the luminal subtype rather than other subtypes, and it denotes good prognosis if it is positive. But it is never predictive for the response to therapy, simply because the resistance is sometimes due to other factors than the molecular subtyping. The molecular subtyping does not tell us everything. sometimes the resistance is due to epigenetics, or we can use other methods for this detection of this resistance, namely as the oncotype DX and the NGS. Actually, it is less positive in non-luminal tumors in general, and you do not need to have all the cells or most of the cells positive. 10% could be enough because this is a diagnostic, not otherwise. Here the mammoglobin is positive. Actually, mammoglobin is more sensitive, more specific, but the GATA3 is more sensitive. We see here the picture above is the positivity for mammoglobin, but for GATA3, some tumors may be diffusely positive with this nuclear reaction, or sometimes they are just moderately positive. It's enough for us to get a 10% positive reaction to declare the case as positive for GATA3. Now we come to a new parameter that was introduced to us by the ASCO-CAP guidelines in 2020, and it clearly states that there is a percentage of tumors that could be ER low, the definition of which will be that it is a sample with low expression of ER down to the level of 1 to 10% of cells only showing this nuclear reactivity for ER. However, the intensity here was not mentioned, so as you see, they're not putting much influence or impact on intensity, but usually it is weak. When the count is low, usually the intensity is again weak. So we're asking ourselves, so what is the benefit of this group to the endocrine therapies that they will get? Is it the same as being highly positive for ER? And actually, some cases are not just, they really are heterogeneous tumor, both in behavior and in biology. And the gene expression profile tells us that they are more related or more similar to the ER negative cancer rather than the ER positive. And here is a diagram showing that ER low tumors are towards the negative hormone, they are basal form triple negative, while the ER high is usually, of course, of the luminal type. So they are more related to the ER negative group of tumors. Worldwide, a lot of investigations have been done on this group of tumors, and it's not that common. The frequency is from 2 to 5% or so, but again, they are worldwide tumors that could be seen every now and then, and they produce some problems, because under the microscope, it's easy to say negative or moderately or strongly positive. But what about those weak positive reactions in few number of cells? Then subjectivity starts to set in. I might see it, others may not. I may say it's weak, some others may say it's negative. And in fact, it's always beneficial to go to high power microscopy. And sometimes it's the only way to see them is by going into very high power microscopy, else you will miss a lot of cases. So as we said, the number is low and the intensity is low. Here comes the problem of ischemic time, which is the time lapse between the biopsy and the formalin fixation. If you have a high count and the fixation is not prompt, you may lose some of the reactivity. Say if it is strongly positive from 80 or 90% down to 50% due to lack of prompt fixation, that might not have an effect. But in these ER low cases, if there is ischemic time, you will lose the whole reaction, and this will transform the case from ER low to ER negative. Whether this has an impact on the outcome of the patient or not, that's another story, but we are there to report what we see under the microscope. So prompt fixation here is the golden rule. And that's why we always say that tissue fixation is a must promptly, and it can put us into a lot of trouble. Please always remember that tissue is the issue. Before we leave the luminals, I'd like to say that if you see an invasive ductal carcinoma that is negative, but the DCIS is positive, we do not mention or decide on the DCIS component. The invasive component is the component that we should be looking for. Again, something else, because it is then like the HER2 exactly. It is only the invasive component that decides on the prediction, not the prognosis. We're talking about prediction. Something else. Now, scientists discovered the fact that DCIS alone, when the disease is pure DCIS, that it can sometimes have an area that is ER positive and another area that is ER negative. And this is called biclonality or multiclonality. It's not like heterogeneity. Heterogeneous tumors have a mix of cells everywhere, and the prognosis will depend upon the average of the whole thing together. But multiclonality, it's as if you're having two different diseases. One is taking over the other, and in that example, the ER negative, which is usually DCIS high grade, takes over and decides on the prognosis. So multiclonality is really important, and it has an important clinical and research implications in real practice. It is prognostic, of course, rather than predictive, but a very strong prognostic effect. So hormone receptor testing, it is important, of course, to do it because it identifies patients who may benefit from the anti-hormone therapy. It should be assessed on all primary tumors upfront. Recurrent carcinomas, yes, because sometimes there is clinical discordance due to the effect of therapy. It's very well known that many times PR is lost after aromatase inhibitors. Bilateral carcinomas, yes, because we've seen that some of the bilaterality may also be different from each other, one positive, one negative. Metastatic carcinoma, whether it is synchronous or not synchronous, can also be tested because of the variability. The DCIS, if it is asked from us, as Dr. Ahmed said, yes, we do it, but we stress the fact that it is prognostic only. Now, ER and PR status can be reliably assessed on adequate core biopsy, adequate. And of course, there are criteria for adequacy. It could be repeated on specimen only if the ER and the PR are negative with no internal control, which is the normal breast tissue, or if it is scanty to start with, or if the nuclear stain is granular, sort of, it might be non-specific, or for any kind of technical defect in the core biopsy material. And now we move to the second type, which is the HER2. Simply, it is a HER2 positive tumor with negative hormone receptors. The GATA3 here might be positive and might be negative, and the mother cell here is a late luminal progenitor cell. It is usually associated with aggressive behavior, poor prognosis, unless the patient gets the targeted therapy, which changed a lot in the prognosis of these patients. And we can apply the methods of detection, either the amplification, the RT-PCR, or the most frequently used, the immunohistochemistry, and lastly, the ELISA for the receptor fragments extracellularly, but this is only for follow-up. And here are the 4 patterns that we can see, either score negative or weak, less than 10% incomplete membranous staining, or more than 10% but complete but thin, and lastly, the positive complete membranous thick the subtype. It is very easy when you have diffuse reaction. All all the cells, most of the cells here are positive with a complete thick membranous staining. But sometimes, again, heterogeneity, tumor heterogeneity is very common with immunohistochemistry. And this is not due to defects in the methodology, but it is a nature in the biopsy or the biology of these tumors. A lot of intra-tumor heterogeneity may be seen, either partial, solid, mosaic pattern, clustered areas in all kinds of distribution you could find in tumor heterogeneity. Again, technical defects could also cause either heterogeneity or inhomogeneity, in which some areas will be positive, others may be negative, or some areas may be strongly positive, others may be weakly positive. But all you have to do to declare the case as positive is, of course, as we know, more than 10% invasive, invasive component, complete thick membranous staining. But what about the score 2? There's a lot of subjectivity in this kind of stain. I might say it's thin, others may say no, it's a bit thick. And even some people claimed to have intermediate membranous staining. So actually we really need to be very, very strict with that by adding the more sure evidence of the gene amplification, either by SISH or FISH. The result should be here. This is the, this is the amplification where the ratio of the gene is more than 2 in comparison to the chromosome 17, that's amplification. Or we started to use a monoprobe chromogen probe, in which if you find 6 or more dots in 50% of cells, that is positive. But now we use the bi probes, in which we have the gene, silver impregnated gene signal, and the chromosome 17 in the red signal. And also what's important is to decide on the ratio between the gene and the chromosome 17, which should be more than 2, and the gene dots amplification is more than 4. We have this diagram to show us that we have to go through the whole thing of the ratio and the number of copy genes. You will get a lot of that in the practical sessions, maybe this afternoon. What about the change in the quantitative change of HER2? Yeah, there have been many papers talking about the change in pattern of HER2 from positive to negative or negative to positive. That happens with treatment, that happens with recurrence, that happens with bad prognosis, and so on. The overall discordance could be as high as 14%, and that's why we say it is appreciable to repeat the stain in cases of recurrence. We know that after the neoadjuvant therapy, if it is associated with trastuzumab, then you might get loss of the HER2 gene expression. Whether these changes are transient or permanent, this is still not very known, but it is the usefulness of this information to guide the patient management is what they all talk about. HER2 low, again, is a new parameter that's been introduced. It's either the +1 or the +2 negative SISH. And by the way, they sometimes toggle, because the disease is never stationary, and sometimes we get cases that are HER2 low that change into negative, or vice versa. But the importance is that the clinical trials, they tried to establish that this group of patients, they can benefit from this trastuzumab therapy, and simply because of, like this one, this is a very
weak staining of the membranous reactivity. Maybe it is membranous, true membranous, or is it cytoplasmic? Sometimes it's a bit ambiguous. But you have to be really sure by also applying high-power microscopy. Why is it that the HER2 low may benefit from such therapy, targeted therapy? Simply because the ER strongly positive or high positivity, they have millions and millions of protein receptors on the cell membrane, while the low HER2 positive cases may show only hundreds or so. And that is why for example, one of the very many papers in the literature recently, they proved that they achieved an objective response rate of 37%, and that's quite a high figure, when trastuzumab was administered together with the DZX, which is very beneficial to the HER2 disease. And this indicates that the number of HER2 receptor molecules, even on HER2 low, which is +1 on the cell membrane, could be in the range of 100,000 molecules. Of course, less than the higher HER2 high, but still good enough to reach the threshold of a unique bystander effect, killing of the tumor cells in this HER2 low disease. Again, like we did with the ER, yes, HER2 low are usually showing luminals expression, luminal A and B, and they have a lower Ki proliferation index that really shows them to be more related towards the HER2 negative group. So the guideline for the HER2 reporting now by the ASCO and the CAP, you have to be very careful with your pre-analytic, that is the adequacy of the material and the formalin fixation. Always include controls using the +1 cases. Always use high-power microscopy, and because of subjectivity, always ask a colleague for a second opinion. And always, as also guided by the guidelines, write the comment of that this case may be eligible for therapy by targeted non-amplified or non-overexpressed levels of HER2. So yes, it identifies patients who may benefit from the targeted therapy anti-HER2, and it should be assessed to all invasive breast cancer and not to DCIS. Recurrent or metastatic cases, yes, it is indicated that you could repeat it again. And you should also follow the guidelines that we just mentioned because of the cardiac toxicity of such a drug, as well as the very high cost of it. So just give it when it is indicated. Now, the last group will be the triple negative. And simply, it is a group that we say it is not, it is not, it is not. But what it is, it's not quite defined. And the cell of origin is, of course, the myoepithelial cell, which is negative for hormone and negative for HER2, and the cytokeratin profile here is changed to high molecular weight cytokeratin. And always include normal breast tissue, and if your biopsy does not include that, then it's a bit questionable. So, because always we think of absence of evidence is not an evidence of absence. Always, always include normal breast tissue for a positive control. We're not going to go through that, but just to give you a hint, it's a very heterogeneous, very wide, broad disease that is very much homogeneous in between them because they have different mother cells. Again, the mother cell could be the stem cell up there, or could be the mature myoepithelial cell down there. And all of them will show triple negative reaction, but believe me, they have nothing else in common. They are aggressive by nature, but they have, some of them may have better prognosis, like the adenoid cystic or the secretory carcinoma, and some medullary-like carcinomas, and that is really because of, again, the effect of the mother cell, whether it is the very immature stem cell above or the mature cell below. Some of them are positive for EGFR, and they are positive for the cytokeratin 5/6, and some of them even are positive for androgen receptor. All that is important when you come to the therapeutic event of the case. Lastly, I'm just going to give few words on Ki-67. It is a very important prognostic marker. It is present in all proliferating cells. It is much better than to grade the tumor by mitosis, and it can really differentiate between luminals, and it can differentiate, it can form a more sort of precise grading, especially grade 2 duct carcinoma that we always just say it anyway. And because of its variation in methodology and cutoff points between 16, now 20, and so on, the subjectivity is still very high. And now it is advocated that those cases with higher Ki-67 more than 20 will receive the CDK inhibitors with hormone therapy if the proliferation index is more than 20. And if the case is really tremendously high or tremendously low, it is not important. You can just do it roughly. But if it is around the around 20% score, then you really, then you really have to calculate more cells. Here are the how Ki-67 could be heterogeneous all through, or it could be present in hotspot areas. Some areas may be low, some areas may be totally negative. You could say that these three photos, although they are from different tumors, however, they can still be in the same tumor due to tumor heterogeneity. You can use eyeballing when it is very high or low, but in the 20% area, you should count more cells. I don't like the hotspot theory very much. The best thing is to do a whole slide scanning. Better still if you have an image analyzer, or better even if you have artificial intelligence to do that for you. Now, for practical points, core biopsy is more reliable than the specimen due to fixation, and always include built-in control. And in ambiguous cases, you have to increase the expression or the count of the cells. Always keep in mind that therapy may change the profile, and always take the history, because they don't tell us, so you have to really extract the history from them, and repeat the immunohistochemistry for recurrent cases in certain clinical situations. Now, some pitfalls we may fall into, but try not to. The pre-analytic, always ask for adequate material, and make sure that the biopsy is really well fixed. The analytic, manual immunostaining is criminal. If you don't have the machine, just send it somewhere else. Don't use expired or unreliable monoclones. And the post-analytic, make sure that you're looking at the true membranous and not cytoplasmic, and the nuclear is a true reaction. And don't miss those low positive cases by using high microscopy, or because of heterogeneity, try to count as much cells as possible. Here are some of the references that I've used in preparing this presentation for you. And lastly, morphology may be misleading, but biology is always the doer. Thank you.
Thank you very much, Professor Nadia. In fact, this was a fancy presentation relating the morphology, the basic morphological and clinical facts, to the root of genetics and molecular. Thank you very much. Now, will we have some time for, we have 5 minutes. Fine, we have 5 minutes for the questions. So please, it's open for the floor. Okay.
Thank you. So the original study was 14% for the Ki-67 to differentiate between luminal A and luminal B. And then at St. Gallen, they say 20%, not based on any study actually. And now there is a recent ASCO guidelines to replace Oncotype DX. I mean, if you don't have it, it's not available or affordable, you could use Ki-67 that's validated. However, they say if it is below 5% or above 30%, you don't have to do the Oncotype, but if it is between 5 and 30, which is a very big gray zone, you have to do it. So as you can see, there is a wide range. So I was wondering about your reference for the Ki-67 of 20%. And then another point regarding this indication for the new medication, amivacyclib, actually it was retracted. You don't have to do Ki-67 anymore to predict response, but it is still prognostic.
Yeah, only prognostic and never predictive. Ki-67 is always prognostic and never predictive. And the first comment, actually, you're absolutely right. But again, the more you count, the better. This is a golden rule. That's what I always say. When I'm in doubt, I always go ahead and do more and more and more counting. Eyeballing here is not enough, but you have really to be precise, and they go up to 500 and 1,000. And that is why the only thing that uses image analyzer is for Ki-67. We don't care about ER, PR, and other, because that is very crucial. And thank you for the question. I do have a question to the audience. Well, you having any problems with the molecular classification of breast cancer in your daily practice? Because I think that technical problems are more important now than scientific. We suffer a lot from technical problems, and let alone the new modifications that have been put for us, that we have to really peep into these sections and use high microscopy, high power microscopy and all that. The thing is, if we really sort of standardize, the most important thing is to standardize whatever you're using and to follow the CAP guidelines. I myself would like to follow the CAP guidelines always, but I'm a bit skeptical about writing this comment down there. I don't know, Dr. Maher, if you're doing that or not. Do you write it always so that's a must? Yeah. Yes, that's, yeah. I do believe that, as we said, and I will always be saying that tissue fixation is a gold standard together with the adequacy of the biopsy. These two factors are not within our hand, but we always say that to the oncologist or to the radiologist or to the practitioner, because it makes all the difference. I mean, we talk a lot about science and nucleolus and nucleus and all that, and the tissue is badly fixed or inadequate. And we lose the whole case because of these two items. So we'd really like to scream out to the people outside, not here, we are all pathologists, or most of us, but always, if you go anywhere, just tell them, please promptly fix the tissue for us and give us adequate material. You will not suffer from having multiple results from different labs, because this is because of you and not because a defect on our side. I do believe so. So thank you.
I have a question for Dr. Ahmed regarding the Ki-67. Do you use Ki-67, as you said in your lecture? How do you use Ki in differentiation between benign, borderline, and malignant phylloides? Is there a cutoff or something like this in the core and excision?
Actually, a good question. Actually, there is, as I know, there is no cutoff point. But if you found it, it is very high, more than 50, it must be, or it will be a malignant in core biopsy. If it is less than 50 and more than 10, it may be between, but less than 10, I think it may be benign. Okay, but actually, very rare I ask for KI in core biopsy in fibroepithelial lesion. It is better to do an excision with safety margin to be sure, as I said before, there is a heterogeneity in the stroma of phyllodes tumor and even in fibroadenoma. In fibroadenoma, you may find areas of hyalinosis, myxoid, hypercellular, hypocellular. So for this lesion, it is better to do an excisional biopsy. And also for all other items, as I said, either hyperplasia, if it is typical, atypical, or low-grade in situ, mucinous lesion, papillary lesion. For this lesion, we are in gray zone, and it is better for the patient to do an excisional biopsy with safety margin.
Thank you.
Thank you very much.